At 11 o'clock on our end. So some people will continue, of course, to stream in, but I want to welcome everybody to being here this morning. It's a special treat that we have Alyssa Benedict with us today. I want to introduce myself, let you know who I am if you're not sure. So I'm Dr. Emily Salisbury, the director of the Utah Criminal Justice Center. If you're not aware of what UCJC is, we are an interdisciplinary research center in the College of Social Work, the College of Law, and the College of Social and Behavioral Science at the University of Utah. We're really very fortunate to have Alyssa Benedict with us on behalf of UCJC today. But before I introduce her, I'd like to acknowledge that this land, which is named for the Ute tribe, is the traditional and ancestral homeland of the Shoshone, Paiute, Goshute, and Ute tribes. The University of Utah recognizes and respects the enduring relationship that exists between many Indigenous peoples and their traditional homelands. We respect the sovereign relationship between tribes, states, and the federal government, and we affirm the University of Utah's commitment to a partnership with Native nations and urban Indian communities through research, education, and community outreach activities. So Alyssa has over 20 years of experience in justice and behavioral health, specializing in the design and implementation of gender-responsive, culturally attuned, and trauma-informed policies and practices. She's the founder and executive director of Core Associates and provides training and technical assistance to government, private, and nonprofit organizations. She's authored and contributed to various publications, models, and resources designed to support practitioners, administrators, and policymakers in their efforts to implement trauma and resiliency-informed approaches. Among them is Creating Regulation and Resilience, a trauma-informed staff communication model that has demonstrated significant success in transforming individual and organizational outcomes. She'll get into talking a little bit about that model in this presentation today. Alyssa, thank you so very much for your contributions today and for helping our stakeholders learn several new skills today. I want to just amplify the work that she's doing, her and her team. It's incredibly important if we're really going to implement trauma-responsive organizations. So thanks so much, Alyssa. Take it away.
Thank you so much for the introduction and the invitation to join you and your team and all of the folks who are on this Zoom today. I'm so excited for the next hour. This is an incredibly important topic, but something I absolutely love talking about. And even more than that, love after presentations like this, connecting with folks like you who are doing such deep work in the field and engaged in such innovative work to push us all forward as it relates to better care for those that we serve. So I won't say anything more about myself than the introduction Emily provided, but I would love to just talk a bit about the next hour. I've decided to offer as much information as I can according to the description you were provided. This can't be interactive in the way that we would hope because it's an hour and it's really designed to provide some really important information, but I really encourage you to use the chat to offer perspective questions. If we have time at the end, would love to invite all of you to provide some information, question probing as well. And if we don't get to that, absolutely, I would love to make myself available after this just for being in community together online and talking about strengths and challenges and opportunities as it relates to implementing trauma-informed practices in our unique setting. So that's how we'll proceed. But again, I will actually make sure that I can see the chat right now and would just absolutely love if you become active on that throughout the next hour. So I'd like to just start by talking about the behavioral health landscape. I know some of you are coming from corrections as well, and some of you work across sectors. So the presentation I did yesterday did some more specific content on corrections, but I wanted to really dig into behavioral health today with all of you. And just acknowledge that the landscape is pretty dynamic right now. I mean, you're all in it, so this will not be unfamiliar, but the pandemic and the way in which we're really confronting social justice issues in this country has introduced quite a bit of strain in the behavioral health sector, but also a tremendous opportunity. So we know that we've seen tremendous increases in anxiety and depression and a host of other behavioral health issues, not only in the general population, but those who are in our systems. And this is really being deemed by researchers as just an extension of what's been described as just a long simmering crisis where lack of resources and opportunities to coordinate, collaborate have really been kind of stoking this fire for a while. And the pandemic and some of these social justice issues have really put us in a whole new realm that we're needing to deal with. And engagement is really important, right? So we've got to operationalize the research on behavioral health that's there and also innovate. And I'm just hearing from Emily and her team that, you know, so many of you are just doing incredibly creative work on the ground in addition to implementing evidence-based practices. And that's the only way we grow, is to hold both the current evidence and then push the field further to expand that evidence base. And so this engagement will really help us better address needs, improve outcomes, reduce the tremendous costs associated with lack of proper behavioral health care and what that cascade and domino effect is across people, communities, and systems. And we want to, again, improve outcomes and make sure that folks are happier as individuals and communities. And so we're just seeing a ton of opportunity within what feels a lot for all of us, not just the clients we serve, but us as providers, like a crisis. You know, we have some more technologies to promote access, and folks are more empowered and knowledgeable. And so we really can forge a new type of behavioral health in this country out of this crisis. Other things I wanted to note just very briefly is that even before the pandemic, when we look at behavioral health, we just see that there's a lot of unmet needs around this country. I'd be really interested to learn what's happened in Utah over the past decade or two, but we just know folks are just not able to receive services, and marginalized communities, including those communities of color and those who identify as LGBTQ+, are really struggling even before the pandemic. And again, it's worsened during the pandemic. So, you know, many more overdose deaths, worsening of existing conditions, increased anxiety. It's just really, again, calling for coordination and cross-sector collaboration. And a really important example of that is when we look at the intersection of behavioral health and criminal justice. That, again, we could talk about just that for a number of hours, right? About there's just, as we see sectors interface in this kind of larger landscape, even economically in this country, and around how we communicate and how we define service and care, just has created a situation where resources are tight. In some ways, depending on the community, the region, you know, the policymakers, what laws are in place, criminal justice systems are serving increasingly folks who have significant behavioral health needs and are kind of a default response in a lot of cases. And so that is a really important interface. And the numbers are pretty staggering, where we're seeing that folks with behavioral health needs, mental illness, are just getting locked into a criminal justice system that wasn't designed to serve folks who are really needing a certain type of care delivery. So our coordination is important, and of course, building a scaffolding of support. And again, I wanted to amplify this concept of disproportionality and culturally responsivity being so important. It's always been important, in particular now. A lot of intention around this, and behavioral health really matters, because we're seeing very disturbing trending around marginalized communities and access and stigma, and receiving poorer care, or in many cases, not trusting to even access care because of the way in which they have felt marginalized in this country and in their communities. So that's something to always lift up. So of course, the really important trend we're going to focus on today is this increasing, ever deepening acknowledgement and attention to trauma in behavioral health agencies. It's been really exciting to see the way in which folks like you have taken this knowledge about trauma and begun to apply it and make sure it's integrated into everything that you do, because we know the research just shows more and more the tremendous impact that trauma has, not only on survivors and the clients we serve, but on us as providers, as human beings. It's just a really important opportunity to pay attention to that research and take it to the next level. It's still, despite all the gains we've made, including in behavioral health, it's not fully taking the impact or taking hold in our agencies in the way that it needs to. And the research is showing that pretty clearly. Lots of barriers to implementing trauma-informed care. And it is considered the most untreated cause of human suffering. And so our implementation efforts matter, and opportunities like this to come together and look at what's the latest research, what are the most innovative application models out there, so that we can take it to the next level, because the prevalence is significant. And we know that, again, we have incredible studies like adverse childhood experiences that are showing us that there's really a number of events that happen early on in the human lifespan that set the stage for behavioral health complexity and challenge. And we know that these traumas just exacerbate or create mental health problems. And there's just strong links between these early experiences. And again, I'm feeling really excited about the increased dialogue and acknowledgement of the way providers carry as human beings a number of stresses and traumas. And that often is invisible in conversations. And our efforts to really focus on client care, which are laudable and wonderful, we have to include ourselves and each other, because we're doing the work, and our ability to come into our own sense of healing and regulation makes us more effective in our interface with clients, and of course, more happy as human beings and as folks doing this work. So there's this really important idea of trauma-informed practice that all of us are familiar with. And I'd love to just introduce a bit of a modification to that terminology and philosophy. We've ignored trauma for so long, for decades, really, it really wasn't at the forefront in the way that it is now. And so in this kind of quest to understand what types of trauma exist in the human population, and particularly the communities we serve in our agency, how can we understand it? What are the links to the trauma we know has existed and continues to exist in our clients' lives and now is impacting behavior, justice system trajectories, entanglement in multiple systems, remaining under-resourced and in poverty because of unmet behavioral health needs? All of that has been, of course, tremendously important. But what we seem to have lost is a narrative of resilience. And so when we talk in a little bit about the neurophysiology of trauma, we're going to also dig into what's the neurophysiology of resilience? What's our hardwiring to recover? What's the capacity we have all at our disposal from birth to heal and integrate stress and adversity? And that's a narrative I really want to promote today that I feel is missing or underemphasized. Again, our progress is incredible. Implementation of very cutting edge evidence-based trauma-informed programs in our behavioral health agencies. We've enhanced our assessments. We've rolled out staff training so that the workforce is really familiar with trauma and its impact. We have a number of ways we've made adjustments to our office culture and how we engage with folks therapeutically, and all of that's wonderful. And I'd like to suggest we add this dimension of resilience. Every time we talk about trauma, let's also talk about resilience, and let's deepen what we're doing. Let's see where we can reach in our agencies to implement and touch policy, practice, and program with this trauma and resilience lens that we haven't had a chance to yet. It's kind of like this opportunity to recalibrate. Where are we? Let's take stock of it. We've done training. We've done a number of things. What's the next phase of trauma and resilience work? And so we'll talk about what that could look like a little bit today. And I always like to include client stories and experiences to humanize and just bring in the spirit of the folks that we're working with, especially as it relates to this concept of resilience. So we'll talk about Carlos briefly, whose symptoms developed over a pretty long period of time. He was physically intimidated for 5 years plus by a peer and had no one that could intervene. His grandparents, when he shared it with them, considered this kind of how kids are. They didn't know he was terrified. He tried to express various concerns and in his words, dread to his grandmother, but his feelings were dismissed, not out of malice, just lack of information about how traumatic this can be. And although he really wanted to be a wrestler, he, over time, because of the lack of ability to access supports, that kind of confidence and vision began to erode to the point where he doesn't want to go to school anymore. And so he started skipping school. And he finally, because of that, it got to that point, all these failed opportunities to support him. Finally, there's a realization that he needs help when the school is realizing he's not showing up. And so what we want to make sure when we're talking about trauma and resilience is so that we can all look at that case and say, my goodness, there's a lot of trauma and disruption there. But we also need to add what else was happening at that time that really speak to this deep resilience that we all have. And in this case, Carlos has exceptional writing skills. We find out after this really escalates and he's skipping school that he's journaling regularly and no one knew about it. And this was a coping mechanism. that he was helping others at school, even while being bullied, by serving as a tour guide to visitors. He found ways when he couldn't connect with peers to find opportunities to connect with human beings. So this touring was with adult visitors, felt safe for him. So he found a way to safely engage in his school environment, even if it wasn't with peers. Viewed by teachers as a model student because of how he navigated his classes. And each class period, every teacher said, this is a kid that we want other kids to learn from, maintain academic honors while he was in school, and adored by his family. So these are the things we want to always be lifting up, because what we get into is this pattern sometimes of looking at problems and deficits, because of course we want to help and remedy and want folks to heal and have access to that. But what we tend to do is we see challenging behaviors and we either dismiss resilience, or we may actually use terms that are very oppressive and cause more trauma and stress, like the ones on the right in red font: manipulative, entitled, needy, dramatic, harmed, even the narrative of victim. Sometimes that is a really important word to use, and sometimes we need to also elevate the narrative of survivor. So we want to reframe how we talk about behavior. And so as we lean into this unpacking today of what do we mean by trauma and resiliency informed practice, there's kind of three things we'll talk through for the rest of our time together. It's not just something that we have as a philosophy, right? I want to be trauma and resiliency informed. We want to kind of know about the latest research that's really helping redefine our workspaces and our interventions with clients of all ages, have a belief system that's related to that, whether for some of us that's a belief in healing at a level that maybe we didn't believe before was possible with some of our really acute clients. And then most importantly, taking the knowledge and the belief system and having some actions that we implement with great intention. So we're going to talk about the knowledge part of this. Many of you in behavioral health have probably amassed quite an amount of wisdom and knowledge about trauma and its impacts and resilience. But just for those of you that maybe are newer to this, we'll really move through quickly some of the key elements of the research that seem to be guiding this effort to be more trauma and resiliency informed at a practical on-ground level in our agencies. So we'll get anchored in those really quickly and then kind of move into what does this mean? What's the action piece? So the first discovery is that the early years matter. And so we talked about that already a bit. And we just really want to emphasize again that from a nervous system perspective, those early experiences that the adverse childhood experiences study described, such as neglect, really create a nervous system blueprint that we will carry with us through our development. And any adjustments to that are really difficult to make if we're not accessing trauma and resilience informed care. And if we're only getting trauma informed care and there's not a cultivation of resilience, those nervous system patterns will stay in place. And they say what fires together wires together, and vice versa. So what we want to make sure is we're understanding there's a pattern that's been created in our nervous systems as human beings based on these early experiences and later experiences as well. We know so many of us carry early traumas in addition to current traumas. And that's a reality that's reflected in our nervous system that we really are compelled to work with in behavioral health, which we'll talk more about. So the early years really matter. They set a stage for our interface with the world. And we're hardwired to respond to stress as human beings. And what I love about this discovery is it's opened our eyes to this incredibly beautiful nervous system that we have, that we're born with, that helps us move through life successfully, including stressors and traumas. And so just a really quick highlight, because this is such a vast topic, but at its simplest level, the most important discovery we're finding here is that we have this ability to mobilize and respond in a relaxation response when we're confronted with a stress or a trigger, when we're experiencing trauma. And so for those of you where this is a bit of a newer concept, we kind of call this the sympathetic nervous system response. It helps us mobilize that classic fight, flight, freeze. It's that inner gas pedal, I call it, that allows us to really face a stressor and manage it. We also have an inner brake, the parasympathetic nervous system, which helps us move into a place of regulation and relaxation and calm after we've successfully navigated the stressor. That's an incredibly important part of the human stress response. that ability to achieve calm and regulation is essential, because it's in that space of calm that we more deeply and permanently integrate the trauma and stress that we experienced. So that I want to really emphasize. The parasympathetic response, that ability to achieve calm, is so, so important. It's where integration and healing happens at the neurophysiological and psychological levels. So that's a really important thing to mention. And here's kind of a picture of what this looks like from a neurophysiological perspective. We've got this system that's been designed to pursue health moment to moment, and mobilize and stay within this window of tolerance. And then again, achieve relaxation and calm when the stressor has passed. And just as an aside, I'd like to say that parasympathetic response, that calm response, really powerful research coming out. Some of the most interesting coming from research post 9/11 and how folks were coping in New York City with the deep trauma of those events. And what we're finding is we actually can stimulate that calm parasympathetic response by being in community with other human beings. So that alone can reshape how we deliver behavioral health, by always making sure there's a community or a relational component to our interventions and our healing modalities, because we're finding that shared experience is a beautiful vehicle for integration of what has happened. The other thing that we're finding is this third discovery, which is that trauma really, this beautiful stress response that we were all born with, is deeply disrupted by trauma. And so that discovery has forced us to see that there's a number of events and experiences in our lives that lead to trauma. So I want to amplify this briefly. Of course, we know abuse, neglect, assault, violence, but there are also increasingly very powerful studies that are showing that there's a deep trauma and stress connected with racism and sexism, genderism, ageism, disrespect because of the abilities you have, homophobia, transphobia, xenophobia, poverty. The way in which these stressors and traumatic experiences live in the body is real. And feel free to email, there's incredible books about the somatic impact of things like racism and marginalization and poverty that we all need to know about, because so many of us are dealing with this personally, but also know that our clients are. So traumatic experiences that are typically on our list of considerations, we need to really expand that. And we now know from this research on trauma and its impact that it's not just a psychological effect where I feel anxiety or depression or like damaged goods or shameful. Those are real psychological processes that follow from trauma, but we know that there is also a deep connect to a neurophysiological experience. So trauma is not just psychological, it's neurophysiological and embedded in the body. It lives in the body. If some of you have probably read Bessel van der Kolk's work, The Body Keeps the Score, which is just a powerful title. What the brain is not consciously aware of, the body does absolutely remember. Again, so that we'll talk a little bit later about somatic interventions and how vital they are to healing and integration in behavioral health settings. We can't just work from the neck up with folks. And cognitive behavioral interventions are excellent, but they are not enough when we're talking about trauma recovery. We have to complement it with interventions that focus on the body and position the client as the expert of their experience in the moment, and be coaches as they navigate difficulty and symptoms they're experiencing and moving into that place of regulation by harnessing their strengths. So it's really powerful, exciting work. And this is, again, a picture of what that disruption looks like. When we talk about this third discovery, it's like a crack in the system. And we either are hypermobilized in the wake of trauma or hypomobilized, which I'm sure a lot of you see with your clients pretty routinely, that kind of too much energy in the system. You've learned the world is unsafe and you're kind of very vigilant, maybe anxious, panicky, rageful. And on the opposite end, some folks may be hypomobilized, where the energy in the body and the nervous system is restricted, and there's depression and disconnection, exhaustion, folks saying that they feel numbed out. What's important to note here is when we're in this place, we don't have access to all parts of the brain, particularly those parts that are helping us to engage in critical thinking and executive functioning and anticipating consequences, future planning, because we're in a survival mode. And it's something that happens unconsciously. So I'd also like to emphasize that as it relates to this graphic, we don't choose to become hyper or hypomobilized. Our nervous system chooses that for us. It doesn't ask for permission. And that's important too. It's something that in my direct service work, because I actually started in psychiatry. It was one of my first direct service experiences, about 4 years in a psychiatric facility. And it's extremely empowering for clients to know this fact that the reactions that they're having are their body's best attempt to keep them safe. So to bring into consciousness the fact that that's happening gives them such incredible power and control. And now they're able to, with our support, bring awareness and attention to this and work with their body towards a different response, which creates a new pattern, adjust the nervous system blueprint in powerful ways. Their self-esteem, their self-efficacy goes up, and they feel more resilient and capable, which is exactly what we want. So this graphic here doesn't have to connote, my goodness, there's an interruption and there's a forever disruption. In fact, this is a tremendous opportunity to bring consciousness to what's happening in the body and heal. We know that triggers are substantial, and the reality of the ways our settings are structured in behavioral health can really encourage triggers and traumatic reminders. That's not our intent. But some of the most exciting work I'm seeing around the country is agencies that are literally mapping a client experience from the moment they enter a door and walk through different spaces, or how folks will respond and create safety with clients in a phone call or a Zoom in the COVID era, right? There's whole trainings that I'm providing with agencies around how you engage on phone and Zoom in a trauma and resiliency informed way when you don't have that three-dimensional space to interact with someone in. But this mapping of someone's experience in space, phone, agency, Zoom, and intentionally creating an environment with them and their ideas and autonomy that doesn't feel triggering, that feels fostering of health, control, collaboration. Because if that's not happening, the triggers are really powerful. And what we know neurophysiologically is when we have a reminder, something in the environment makes us think of what's happened to us, quite unconsciously, the whole body will now actually mobilize as if that threat is real. So we have to be really mindful of that. And we know that, again, the stress response we are all born with is disrupted. So now there's a trauma-influenced response, and we find that survivors can get stuck here. There was an overwhelming event or a number of events. And so now there's a way of responding in the world that's protective, at least at the time of the trauma, but there's this ability to kind of recalibrate is often restricted because they don't have access to trauma and resiliency informed support. So that's where our role comes in. It's critically important. Just a quick clinical example of this, that it shows how kind of deep this can go. I'm sure many of you have worked with folks who are engaging in self-harming behavior. There's been a lot of stigma around that, a lot of misunderstanding about that. And on the surface, we can, of course, be thinking of this as it's a way to escape the pain of trauma. There's also quite a bit more happening. That act of making an adjustment to your body through a cut that draws blood, et cetera. It's, releases endorphins, neurotransmitters that are very similar to morphine, flood the body to provide some relief. And for some, the act of doing this is not necessarily to create numbness or to dissociate, but actually to disrupt the depersonalization they feel in the wake of trauma, to actually disrupt the dissociation they feel. So to hurt oneself is a way of actually, I'm here, I'm a person, because the rest of the time they're quite disembodied. So there's lots of ways to even more deeply understand the behaviors that we see among our clients, and allow more room for the possibility that there could be something even more unique going on than what our typical assumption is around self-harm. And we could look at a number of behaviors and see some of these really deep understandings that are driven by the latest research. So the last discovery, which is my favorite, is the fact that we're hardwired for resilience, which is why, again, trauma and resiliency informed policy, practice, programs. I think that narrative is so important because it's getting lost a bit in the shuffle. And this is basically our ability to adjust and thrive after we've been exposed to stress and trauma. we absolutely can bounce back. And we do that in at least two ways: by drawing from the resources we have, which we tend to spend less time on, I think, in our interventions, but also the external resources available. And that's where we come in. We are, in part, like one of those key external resources that our clients can draw from when they're wanting to find that capacity to heal and integrate. And the more they can access their own strengths, and certainly some of the resource that we provide, even in our empathy or our pointing to some resources and opportunities for them, the more healing is possible. And some of the research that's been debunked from the early 70s is the idea that we're either born resilient or not. And instead, we're finding that resilience is a capacity we all have, and it develops in the context of empathic interactions. That's been one of my most favorite lessons learned from the latest research. They're doing fMRIs and seeing how humans respond to empathic engagement. And we're finding this deep resilience cultivated in those interactions between human beings, which has a huge implication, again, for the settings that we create in behavioral health, from phone calls to group processes, to how folks move through space, to the types of interventions that we provide, to the assessments that we do, the questions that we're asking, even the act of when someone comes in to meet with us, instead of how's it going, just to start with a strength. What are you the most proud of? Before we talk about the other things we hope to get to, what are you proud of today? And to get that brain oriented to capacity and that body to feel a sense of calm because of an empathic engagement that they're feeling and experiencing that enables them to access strength. More good news, we know that this capacity for resilience is echoed in tremendously important brain changes. Yes, we know even hippocampal volume in the brain, for example, can change after traumatic stress. But we also know that we can heal the brain, we can heal the body, and the ability for the brain to change neuroplasticity or create new pathways through neurogenesis has been documented over and over in the research. And there's even more research coming out about how we can support that rewiring. It's essential to healing and deeply hopeful for us as providers, as human beings ourselves who carry stress and trauma, and certainly for our clients. And so all of this has led to various iterations of what folks have called the principles of trauma-informed care. These are from SAMHSA, probably really familiar to you. Harris and Fallett have principles from 2005 that have had tremendous staying power. I believe these SAMHSA principles build on that. And what we're basically seeing here is that we're wanting to create spaces where we can bring these principles to life, because these things are exactly what were taken from our clients with stress and trauma. They were not able to feel safe. Their trust was violated. Choice was restricted or not present at all. Healthy power was not available to them. Absolutely devoid of collaboration around how to move through a moment, and a tremendous lack of respect. So it's our duty to bring these to life pretty much every step of the way in our engagement with clients. And I would also like to add, with each other. Clients feel the way we relate in our spaces. And so that's one reason to lift these off with each other. But another reason is it creates our own regulation as a team. I'm finding increasingly in my work with agencies around the country that clients are really picking up on the ways in which teams are stressed and traumatized as providers working cross sectors, for example, and very different messaging from multiple people, which replicates trauma for clients and makes it hard for us to engage in the teaming that we need to do to provide stable care with some basic consistency. So we've got to, for so many reasons, lift these off. And what we're hearing in focus groups with staff is when these principles are present with their team functioning, their morale is up. They feel like they're making a difference. They're not moved to jump agencies to find a different environment. And they feel like they themselves are not bringing stress home into their families and communities because the work feels better. So those are important. And again, as I mentioned, the reality is we've got a lot of work to do to adjust the way in which we deliver programs, enact policies, practices. I think of things like level systems. Some behavioral health agencies have phase systems and level systems, and all these different things that we do to support clients some of which can be really incredible and very much aligned with what we're talking about with trauma and resiliency informed care. Some seem like they're resonant with the research, but they're really not. They may be antithetical to these principles. So that's why I'm so grateful to Emily and her team for conversations like this, because it gives us permission to stop and say, let's just take stock of what we're doing. What's really strong? Where's there an opportunity to get better? So that brings us to, some of the key highlights from the research that bolster our knowledge or reinforce the knowledge that we have, that hopefully is connected to a belief system that's also bolstered around what's possible. And now we're into action. And so I'd like to suggest a framework, 3 principles that can help us kind of have those conversations in our agencies about what's possible and what's required. And when I mentioned earlier, there's more work to do, what's the next phase of work that we'll do to really lift up trauma and resiliency informed practice in our agencies, and then as individuals, right? There's the individual commitment and then the organizational commitment, and to have those 2 things interface is powerful. So it's kind of just 3 simple ways to start the conversation. We want to make sure that those principles of trauma and resiliency informed care that I just showed around safety and collaboration, support, respect, healthy power, we want to make sure our environment, whether it's on a Zoom, on the phone, or in an agency space, actively meets those needs, actively lifts those things up. And then we want to make sure that the interactions between human beings in that environment reflect those as well. What we're finding with survivors is when they see a staff member talking to another client, they are not just experiencing, a witnessing of another interaction, but that interaction lands in their body too. That research is compelling. We're calling it like the relational field. There's a field of interaction that's impacting everyone, even if it's just two people speaking and it's not a direct communication with us. So the interactions in the environment matter to those who are interacting and those who are witnessing those conversations. And then we need to, as we create, 1 and 2, those 2 principles are around prevention. How are we actively creating a space that's trauma and resiliency informed in everything we do? But also, how do we respond not only to when there are challenges that come up in that environment? There's an argument, someone threatens a peer. The number of things that I'm sure you're managing in both your group and individual work, maybe someone is threatening to you. Maybe someone gets upset during an assessment, is refusing to speak with you and move further in that conversation. There's all these, what I call ruptures, but we can move into repair. And we have to be intentional about what that repair looks like. And then also not just focus on ruptures, but deep success and capacity that we see, and to reinforce that. That's, again, building that resilience to not only look for what will we do when this happens, but also identifying the behaviors that are safe, effective, supportive, and amplifying those for everyone in the environment. So that can be a framework that you use, because there's this idea of trauma having an ecological component where our nervous systems are growing and healing in these contexts, in our behavioral health settings. And everything we do has the potential to create that regulation or detract from it, to cultivate resilience or restrict it. So that hopefully can motivate us to kind of look and do a bit of an inventory. So this PowerPoint is an example of what that inventory could look like. We could look at all the primary ways in which clients interface with our systems, with our agencies, take the principles of trauma and resiliency informed care and say, how are they being brought to life during an intake? What does our case management look like, and how do the principles operate there? How do they operate as part of our reentry or transition or discharge planning? So that's an exercise where you could take 10 contact points and have your next 10 meetings be an opportunity to kind of mine for what's going well, and to consider the procedures and routines that are part of what you do, the interventions that are part of your kind of program and intervention profile at your agencies. Just be thinking about another exercise, like which of these can be really triggering, even if we have to do them, and how can we redesign those? And I would encourage the redesign to be very client driven, meaning let the clients tell you, this is how we can make this feel better. They are tremendous repositories of wisdom, creativity, and ideas. So the more we bring impacted folks to the table to kind of redefine our practices and our approaches, the better. So the other things that we'll talk about for the next kind of 20 minutes or so is kind of a very concrete communication model that's also part of this action. There's kind of organizational analysis, policy development, program implementation. The other piece we're finding is the way in which we engage interpersonally in the moment is critically important and actually supports all the other things that we're doing. If I go to a really powerful group that addresses trauma and helps me to build skills, but then I move into another environment where I don't feel respected, my resilience isn't cultivated, we're not going to get as much mileage out of those investments and other interventions. We need kind of a baseline of communication and interaction with clients and each other that can create a resilience atmosphere, and CR2 can help us do that. So it's really something that integrates a lot of the micro skills all of you know, like reflective listening and emotion labeling, but it puts them in a specific package and framework that is essential for survivors. And I'll show you that. It's a 3-day training that we offer. You'll get a nice overview today. And I want to emphasize that it takes a lot of what we know around essential skills with clients, with survivors, and puts them in a specific order that allows us to help that person move into a place of regulation and cultivate that resilience that's really needed for them to engage in cognitive tasks like goal setting and planning and finding a job and considering their substance use recovery goals. And it really helps us, this type of communication that I'll show you, to do a whole bunch of things. Lots of the day-to-day tasks that we do can be enhanced when we use this type of communication as we do them, as we do an intake, as we facilitate groups, as we do searches, if that's part of what we have to do as an agency. And so it's also anchored in some core beliefs. I want to highlight the one at the bottom. It's anchored in not only the belief that folks have strengths like we've been talking about, that these innovations in neuroscience are hugely important to apply all throughout our agencies, but that we as staff need to be supported and regulated ourselves if we are going to be effective with our clients and with each other. Just another client to highlight that's just a powerful example of how folks are impacted when we communicate and engage in powerful resilience-based ways. This is my colleague Vera, who said that she was struggling with pain and addiction throughout her whole life, moved through multiple systems, and it really wasn't until her public defender, after multiple interfaces with all folks in the system, the first time someone made her feel capable was after she was system entrenched and it was a public defender, who basically said, I think you're a beautiful person and you have a lot of capacity. And it was that one moment after everything she had been through that she describes as causing a major shift in how she viewed herself. And she tapped into her resilience and was able to move forward very differently. And so it shows the power of the role that we have as staff and folks intervening. So here's a picture of the model. Again, this is just a brief overview. And the thing I would love for you to leave with as you look at this and understand it is that every communication that we have, no matter how much time that communication involves, a 5-minute interaction with a client, 2-minute conversation in the day room, a 10-minute phone call, a 30-minute Zoom that's more therapeutic, whatever that engagement is, there's really a need to break the communication into 2 main parts or phases as they're identified here, where the first phase is really designed to create regulation. And there's a number of skills and strategies we use to do that I'll talk about. The second phase is our opportunity to engage in a collaborative action planning process about whatever the need is or the interest is that our client has. And it's in phase 2 that typically we find, I know I've been trained early on in my career to kind of run the show with my engagement with clients. This is what they need. You need to help them see that they need this and get them access to it. What we're realizing with trauma and resiliency informed care is that is undermining, and that the best, most effective approach that yields optimal outcomes with clients is to empower them to steer their own plan, to architect their own plan with our support about anything, anticipating a tough visit with a child, going to a new job for the first time, talking through substance use history and moving into goal setting about recovery. Whatever the conversation is, it's essential that we front end it with just some real intentional strategies as providers to help that person come into full regulation. And I want to emphasize, this doesn't have to be if they're in crisis or they're escalated. Phase one can happen every single time, even if the person comes to us seeming pretty calm. And the reason for this is it facilitates that healing and integration from past experiences. So if I come to you and I'm really worried about my first visit with my daughter since the reunification process started, and I'm not upset or crying, but I'm just telling you I'm really concerned, we want to really ask some open-ended questions. So in phase one, there's a couple things we're doing. We're anticipating in the hold on phase, that's our pause. And we're thinking in our mind, all right, what are the underlying needs here as this person speaking? And then we're going to ask some open-ended questions and elicit information. Tell me more about how you're feeling about your daughter. Wow, you mentioned there's a lot of fear. What is fear? Like, how do you notice fear? How does that show up for you? And just kind of, when's the last time you saw her? Tell me about a time when it felt really good to be with your daughter. And then any information we get, we acknowledge. And that's really powerful. Again, anchoring it to the brain science, when someone is acknowledged, that helps move them into regulation. It builds rapport, and they're more likely to share more. And what's wonderful about that is it's a voluntary share more versus a coerced or kind of, please, you got to tell me more, I've got to understand. But this voluntary opening that actually sets the stage for a really powerful phase two, because we have more information that's unique to this person and their experience. So that acknowledgement often leads to more dialogue. And then before we move into problem solving, we want to review, which is basically a way, again, from the brain science perspective, to say, here's what I've heard so far. Is there anything I'm missing? And to, again, offer that really healthy control where that person can offer more information, maybe correct where we've misunderstood. And then before we go into phase two, we invite them to let us know if they're ready. And so I always say to the folks in the CR2 training, you want that to be an explicit invitation, where it's, hey, I'm really grateful you told me all of this. I'm wondering if you'd be willing to talk with me and kind of brainstorm about next steps. It's not enough to just acknowledge and validate and leave it there. Wow, yeah, I get it. Like, that sounds really tough to worry about how it's going to be with your daughter. It sounds like the last time there was a fight that ensued during your visit. So yeah, this sounds really tough. Thanks for letting me know. That is not enough. It's important, it's necessary, but not sufficient. We've got to add a phase two that helps them move into a place of effective action. So phase two is about, hey, what are some options here? So we reflect what that person really needs, maybe any rules or parameters that your agency has. But then you move into a process where we're inviting her or this person to explore possibilities. And that's where we really need to be quiet at first, which can be really hard, again, because of our training as problem solvers. And we have deep knowledge and deep wisdom about this person, about the work, and we want to share it. But we really need to hold off on that and let them bring forth ideas first. The act of being said, what do you think? Being encouraged to now go into that thinking process and share it with someone who will respect and hear it is rewiring the brain. It's creating a new template for the nervous system that they can carry with them into places of recovery and healing. And this is just in a conversation. So I'm not overstating the power the power of healing that can happen in even 5 minutes. And then the only other things I'd like to say about phase two is that there's, after we explore possibilities, we again walk alongside them in the conversation to make a plan, and we affirm the whole time we're having this conversation, phase one and phase two, but definitely at minimum, as we're engaging in this kind of think tank together with the client, we want to affirm and say, what we notice that they're doing creatively, some of the skills they're bringing forth, to label, wow, you were really offering lots of different options here. And they hear that, and then they lean into it for the next time. And then the whole thing wraps up with a review. You can use this type of communication to receive a person for the first 5 or 10 minutes, and then get ready for therapy, or to receive a group and get ready to run a group process. You can use this to set up a skill practice. Let's say you want to do work on some cognitive behavioral skills. You can start with CR2. It brings this person into regulation. And then at the end of phase 2, you've now decided what skill we're going to work on together, how long we're going to work on it. And you move into this really wonderful place where these other interventions that you've invested in at your agencies can take shape with much more success. What we're finding is that a lot of the cognitive behavioral and other interventions that we're using, we're sometimes imposing on clients who are not sufficiently regulated to benefit from them. So CR2 can set a pick for these interventions, and we're training staff around the country to not only use this with individual interactions with clients, to use CR2 to get ready for a motivational interviewing conversation, use CR2 to get ready for a structured skill practice, use CR2 with a group. 2 or 3 minutes at the start of the group, you can do this model of communication with 8 or 10 people and then move into the group content. So it's really dynamically used. And another thing that we do is we talk about, as we're using the CR2 model, part of our training is to really make sure that we provide staff with space to develop our own regulation skills and our capacity to be present to the work. It's deeply stressful times in general, but especially now, as I mentioned, when we kind of started today together around the pandemic and all these really powerful social justice issues that are being confronted in new ways, different folks at the table. And so there's a lot we're carrying, and the work is hard. On top of it, it's always been hard when we engage with folks who've been harmed and are suffering. So we don't have the luxury in our work in behavioral health to in the middle of a client session or a phone call, say, hey, I'm going to go do yoga, or I think I'm going to go have dinner with friends and then come back when I'm really ready and present. We don't have that luxury. Yes, we want to build the capacity to develop our regulation skills in our homes and communities outside of the work, but what do we do when we're in the thick of it? And the 3 R's are a very portable technique that we teach as part of CR2, where literally grounding and breath work that's accessible. Like I'm doing the 3 R's right now as I talk with you. And you don't see it, it's really private, but it's super effective because it helps us track where we are as we're speaking and move into a place of regulation so we can respond in a way that brings all our skills forth. The same way the client brain can kind of restrict critical thinking when clients are struggling, same thing happens with us. You all are carrying a tremendous skill set as you do this work. You want to be able to access it, and it's really hard to access it when we're dysregulated. The client maybe insults us, a peer says something that we feel was really offensive, or maybe we're really worried about someone we're working with, and that's dominating our mind body. The 3 R's can help us get through those moments. So there's a couple of things I wanted to mention, and I believe you'll get copies of these PowerPoints. I just want to say that there's ways to adapt CR2 and that type of communication for various presentations that folks may have around mental health. If they're dealing with hallucinations, if they're dealing with disordered thinking, and if there's kind of affective flattening, silence, lack of engagement, for all of those ways that folks are experiencing themselves, in all of those cases, create safety and regulation by keeping the stimulation low. And the 2 tips I'd like to add to that is the way our body is in that space can create regulation for their body. So if our knee is going up and down, that creates agitation in them. If we are relaxed in how we're sitting, even on a Zoom, leaning in with interest, that's called co-regulation, where they are borrowing in their place of dysregulation. They're co-regulating with us. We're bringing that to the conversation. And then the other thing I'd like to lift up is titration. Titration from 7th grade science class, you all probably know, if you have a substance, you have a dropper of a new substance, and you drop that new stimulus into the existing substance one at a time so that it can titrate, that there's a way for it to integrate before we pour more in. And that's something that we're encouraging with folks who have a level of acuity around their symptoms. It's not that CR2 can't be used. It can be tremendously helpful, especially when we have the CR2 conversation and with titration, where our sentences are shorter, there are more breaks between them, and there's more opportunities for us to pause and see how is this going to integrate with them, and just give them that time because they're struggling with either disrupted thinking or paranoia or hallucinations. So it can be very, very powerful. If all we do is these three things in red, regardless of the acuity, it can be really, really powerful. So we have a whole module in CR2 that digs into that. And then we have some somatic tools that we can integrate into the model. What I'd love to say about that is, this is what I hope is the next phase of trauma and resiliency informed practices across sectors. Again, cognitive behavioral interventions are tremendous. They have a value and a place in the work. It should not be instead of some of the deep somatic interventions that we're finding are essential for survivors. If we know that trauma lives in the body, we need to use tools that help folks safely access the body. What we're finding is even as mindfulness, yoga, and other body-based practices are entering behavioral health, we're not delivering those interventions in a trauma-informed way that honors kind of the somatic grounding that folks need. So I'll give you a quick example with breath work. I've noticed a lot of the agencies I work with are doing really pretty beautiful mindfulness practices around breath work. But with survivors, we really have to move through those practices differently. We have to use invitational language. So instead of, hey, let's take a deep breath, doesn't that feel good? We might say, I wonder if we could take some time to notice the breath. Does that feel comfortable for you? Healthy power and control. I'll do this with you, collaboration. You don't have to breathe in deeply or out any longer. Just maybe notice that the breath is there and tell me what it feels like for you. Just encouraging them to enter the body